Hi everyone, this is Keisha again. So this is the third and final video of the rhythm analysis videos. And so in the first two, I've talked about the different sinus rhythms, atrial dysrhythmias, junctional rhythms, and now I'm going to start to talk about the ventricular dysrhythmias, as well as asystole, pulseless electrical activity. I'll briefly touch on Pacers and how they're depicted on the EKG strips, and then also talk just briefly about premature atrial contractions and premature ventricular contractions. So the first ventricular dysrhythmia is this one. So VTAC, or ventricular tachycardia. Ventricular tachycardia. So with this, I mean, you can try to use your steps, but it's going to be pretty obvious as you're looking at it. It can be irregular, but the thing is, it's so fast and so unique and bizarre looking on its own that you'll quickly kind of throw your rhythm method to the wayside, because you'll see there's no P waves to measure, there's no PR really to measure. It's pretty regular, it's fast, it looks pretty similar to this, wide ventricular beats. So VTAC, or ventricular tachycardia, is something that if you see it on the monitor, the first thing you want to do is check your patient for a variety of reasons, right? We always want to monitor our patients when we're monitoring our rhythms, but with VTAC, this can be caused by maybe someone's brushing their teeth and they're hitting their electrodes. It can look pretty convincingly like ventricular tachycardia. So that's just an error. But aside from that, if it is true, real ventricular tachycardia, it can be with a pulse or without a pulse. So sometimes patients can perfuse these beats. So it can be with a pulse or without. That's where the patient assessment really comes into play. You would want to instantly check your patient, and are they sitting there talking to you? Whether they feel good or not so good. If they're sitting there talking to you, they have a pulse with their VTAC. And in that case, it doesn't mean that we take it lightly. It's just that the course of action is a little bit different. VTAC with a pulse can quickly turn into VTAC without a pulse. And so we do still usually get the crash cart in the room. We notify the MD. We make sure we're continually assessing them. The nurse never leaves the bedside. And we're checking their blood pressure, checking their tolerance of it. Medications we can give with VTAC with a pulse include amiodarone as an antidysrhythmic. We can give beta blockers to hopefully try to slow it down and get them out of it. And then we can cardiovert or shock ventricular tachycardia. In the case of having a pulse with it, it would just be a little bit more controlled, in that we might be able to give a little bit of light sedation, some pain medication, get anesthesia at the bedside, and do a little bit more of a controlled cardioversion. To hopefully, what we want to do with that cardioversion or defibrillation is shock that rhythm, stun the heart, and hopefully get it to pop back into a normal rhythm. So that's VTAC with a pulse. Let's say you see this on the monitor and you look at your patient and their eyes are rolled back and they're not responding to you. You check a pulse and there isn't one. So it's VTAC without a pulse. In that case, that is an emergent code situation. It's a life-threatening dysrhythmia at that point. And so immediately you start compressions and activate the code system, emergency system. In that, we'll continue doing compressions, we'll intubate, and we'll give meds. We'll give amiodarone still. We'll give epinephrine, and kind of follow that advanced cardiac life support protocol. And with that, we will shock it too. It's going to be a defibrillation. And so this is considered a shockable rhythm. The heart is still doing something. There's electrical activity happening in the heart. It's not the electrical activity we want, but there's electrical activity going on. And so by shocking it, there's something that we can intercept to hopefully kind of reboot the heart to get it into a normal rhythm again. So VTAC without a pulse is an emergent situation. You do CPR. There's medications we give and we shock for VTAC. Okay, so that's our first ventricular dysrhythmia. Next is something. Actually, I'm going to rewind. One more type of ventricular tachycardia I'd like to cover is something that might look like that. And what we call this is it's VTAC still, but we call it torsades des points. And that's a French term. It means twisting of the points. And it's ventricular tachycardia, but it's unique in that it gets skinnier and then wider, skinnier and wider. It's a certain type of VTAC. And for this, it's caused by magnesium deficiency. Okay, so you see this rhythm and you can likely associate it with mag. And so if there's a code situation, they have pulseless VTAC and it's torsades des points. When the code team arrives and the pharmacist arrives, they have magnesium in their medication box, and we give a mag replacement for torsades des points. Okay, on to our next one now. So this one is ventricular fibrillation, or VFib. Ventricular fibrillation. This one is always pulseless. Again, when you see this on the monitor, you instantly assess your patient. It may be an issue with the leads. If they're talking to you and they are alert, they aren't in VFib. It may be an issue with your monitoring leads. But if it is true ventricular fibrillation, there's never a pulse. And that's because this is totally chaotic electrical activity that's going on. There's no mechanical contraction that's happening with ventricular fibrillation. No cardiac output, there's no perfusion happening. And so this is always a code situation where you start CPR immediately, we'll intubate, we give epinephrine, vasopressin, these different ACLS, advanced cardiac life support drugs. And with this one, since it's still something going on in the heart, there's electrical activity, even though it's not what we want, we can shock it, okay? So we can shock it and hopefully intercept that rhythm, kind of reboot the heart into what would be a more normal rhythm. So VFib, the heart is essentially just doing this. It's quivering. There's nothing happening. There's no contraction happening. It's quivering. So main takeaway with the ventricular dysrhythmias is that VFib is always pulseless, and VTAC without a pulse, both of those, you always shock. They are shockable rhythms because there's some cardiac electrical activity going on, so there's something that we can shock, and so we shock it. And give meds, of course. Those are our ventricular dysrhythmias. All right, next one, this one's easy to draw, is asystole. So this is complete cessation of any electrical activity at all in the heart. This is very, it's indicative of poor prognosis. It's always pulseless. It's always a code situation, CPR, medications, everything. Again, with this one, of course, you're assessing your patient right away. If you see this on the monitor, you don't want to jump and assume it's always asystole, because they could have a lead off. If they're sitting and talking to you, they are not in asystole. But as you assess your patient, and you would check for a pulse, and this is always pulseless, asystole is. So with this, good CPR, intubation, epinephrine, vasopressin, those ACLS medications again. The main difference is we do not shock asystole, so no shock. And so why do you think that might be? It's because those ventricular dysrhythmias, as I talked about, I emphasized that there was something to shock, right? There was still electrical activity going on, even though it's not what we wanted. There was something, so we could intercept it and shock it and try to get it in its normal rhythm. With asystole, there's no electrical activity going on. There's nothing to shock. There's nothing to intercept. And so, as it was taught to me when I started in cardiac ICU, they said if you put electrodes, cardiac monitoring leads, on a rock, it would be an asystole. That's what its cardiac rhythm would be. And so you can't shock a rock. There's nothing there. And essentially, that's what's going on with a heart that's in asystole. There's nothing to shock. So, no shock advised. CPR, meds, and then if it can turn into VFib then, hopefully, if we get a rhythm back, then you can shock it later on in the code. But right away, as long as you're in asystole, there's no shock. Okay. So, the next one. So you might be thinking, this looks really normal, and maybe it is, and wow, I go through all my steps and everything looks great, so why is it being included right in this part of the lecture? And that's because just because you have a cardiac rhythm on your monitor does not mean that there's mechanical capture, okay? And this lends to the importance of assessing your patient along with your cardiac rhythm, your monitor. This is what we'll call pulseless electrical activity, or for short, PEA. To me, as a nurse, as an ICU nurse, someone familiar with rhythms, this is the scariest rhythm to me. And the reason is, it looks normal on the monitor. And if someone's hooked up to telemetry and they're on a general floor where they don't have the luxury of having a pulse-by-pulse blood pressure monitor like an arterial line, or maybe they don't have a continuous sat probe. If they're just hooked up to telemetry, the teletech or nurse is not alerted that anything's wrong if they're in PEA, because the cardiac rhythm, the conduction, the electrical part of the system is working, looks like it's working fine. But with PEA, there's no pulse, there's no perfusion. Simply electrical activity, no mechanical contraction. So in the ICU, we have the luxury of arterial lines, which we can monitor blood pressure beat by beat. And what we would see is we would have, a normal looking rhythm for cardiac, but then your arterial line, which would look something like that with normal beats, slowly just goes to nothing. And then your SpO2, which may have, a nice, will just go to nothing. You'll get, random numbers, maybe a question mark. And in critical care, when we see that, we jump and we run to check, because something happened here. And it can be that it's pulseless electrical activity. So with this, obviously there's no pulse, so it's a code situation. We do CPR, we give epinephrine, give meds, intubate, do that whole thing. There is, with pulseless electrical activity, there's no shock with pulseless electrical activity. So yes, that is PEA. Okay. touch on pacemakers. And this was not in depth, but I just want to show you the different types of pacing and how they might be depicted on an electrical reading. So you can have atrial pacing, you can have ventricular pacing, or you can have both. We'll call it AV dual pacing. With atrial pacing, you'll see a spike right before the P wave. You'll have a spike, P wave, QRS. Spike, P wave, QRS. So your spike is going to be it's going to look like a white line or maybe a green line depending where you're at on the monitor, and it looks separate from the rhythm. It's a vertical pacing line. With atrial, it's only pacing the atria. So it's essentially taking over for the SA node. It tells the atria, hey, it's time to contract, and the atria does, and we get a nice atrial depolarization with the P wave, and then follows the normal conduction pathway, and we have a QRS and starts over again. Ventricular is we totally bypass the atria, and you'll see a spike and then a QRS, but it's wide. And why that QRS is going to be wide is because when the impulse comes from below the bundle, so from within the ventricle, it's going to be wider than 0.12 seconds. So no P wave with that one. You'll see a spike right before a big wide QRS. And then if it's paced atrially and ventricularly, you'll see both. You'll see a spike, and then a P wave, and then a spike, and then a big QRS. So you'll see 2 spikes per beat. So that's just a little bit about what you would see on a monitor for the different kinds of pacing. Okay, and I just want to end with premature beats. So there's a few different kinds of premature beats. First being that I'll talk about are premature atrial contractions. Typically, or PACs, we'll call them. Pretty benign, usually. They can be caused by stress, by different stimulants, drugs, and they're pretty benign, though. We don't get too concerned with PACs. They can be, with PACs, there's 2 different kinds. There can be conducted and non-conducted. So non-conducted and then conducted. It's just like it says, premature atrial contraction. So it's an early depolarization of the atria. And remember, depolarization of the atria is P waves, right? That's how it's depicted. And so non-conducted might be shown by, you might see a little early P wave, and then it starts over. So there's actually 2 PACs here, right here and right here. So what happened in this rhythm, you have a normal, let's say normal sinus rhythm underlying, and the atria just decided, okay, I'm going to fire, I'm going to depolarize, and it's early. And, it goes through with the atria, and the atria contracts, depolarizes. But as it's going down that, it comes from up here. Once it gets to right here, the ventricle says, hey, stop, it's too early, I'm not going to contract. That electrical pathway ends. So it's non-conducted. And it's all you see then is a P wave. No QRS attached to it. A conducted one, as you can probably already guess, is just an early beat that's all the way conducted through the pathway. So the atria decides, okay, I'm going to contract, and it's early, and the ventricle says, okay, sure, why not? And it contracts, and you get a QRS then too. So P wave with the QRS coming early, it's conducted PAC then. And again, you monitor your patient, but they're usually pretty benign. And then the last kind of premature beat is a premature ventricular contraction. So PVC. And what these ones look like are, it's an early beat that's originating from within the ventricle. So you can have any underlying rhythm. What it looks like is an early beat that comes and it's wide and bizarre looking. It's going to, your QRS will be greater than 0.12 seconds. It's wide and bizarre, has an abnormal shape, and that's because it's originating from within the ventricle, and so it's wide. And with PVCs, a few of them here and there, rare, are pretty normal and benign. They can be indicative of electrolyte imbalances or different irritability within the heart, and so we will check electrolytes such as potassium, magnesium. It may be as simple as needing to give them a potassium or magnesium replacement. And then also we may look at if it's affecting the patient. So are they perfusing these extra beats? So if someone is having multiple PVCs and they aren't perfusing them, then we may need to do something more with it. So those are PVCs. So that concludes my videos on cardiac rhythm analysis. And again, these not meant to be 100% comprehensive and to include all rhythms that you would ever analyze. These are some pretty common ones, and hopefully developing a method to analyze them will be helpful in your practice, in both clinical and then as you become a nurse. So thank you for watching my videos. I appreciate it.